Okay, Chapter 40, Patients with Special Challenges. When you look at the title, Patients with Special Challenges, you're going to have a variety of patients over your career that are going to pose special challenges, and many of them won't have special technical needs. Um, Things like homeless patients and obese patients and technology-dependent patients are all going to pose special challenges to you as a provider. Um, some myths that we need to certainly discuss as part of taking care of patients with special challenges is that if part of the person is different, the whole person is different. And that's not true. Just because a person has a disability doesn't mean that that disability should define them or change the way you do your assessment at all or care for them. One of the things that we also see occurring when dealing with a patient who has a special need is talking about the patient rather than talking to the patient. And I don't know why some find that uncomfortable to talk to a patient with a special need. But that's where we need to begin. Again, just because they have a special need doesn't mean that they are unable to communicate. Let's start first with some physical challenges with sensory impairments like a hearing impairment. Deafness is defined as either complete or impartial inability to hear. You can have conductive hearing loss. There's a variety of different hearing losses that you can have. One of them is conductive. Conductive hearing loss is a problem with the transfer of sound from the outer to the inner ear. Sound waves are blocked and they cannot reach the cochlea. This can be caused by earwax accumulation, can be caused by an ear infection, can be caused by an eardrum or middle ear injury, and oftentimes the deafness is temporary and can be reversed once you remove the earwax or clear up the infection, those sort of things. There's a sensor and neural hearing loss, and this is where the tiny hair cells in the cochlea are damaged and destroyed. The auditory nerve may be damaged, and as a result of that, sounds from the cochlea to the brain are not transmitted, so the brain never gets those sounds. Presbycusis is hearing loss from changes in the inner ear, the auditory nerve, the middle ear, or the outer ear. It gradually gets worse as a person ages. First to go are the higher pitch sounds. Causes of this may include very loud noises, head injuries. It may be hereditary. Could be the result of illness or infection, or the result of certain prescription drugs. Tinnitus is a ringing or a roaring sound or a hissing in the ears. It can be caused by loud noises over 90 decibels. It's a symptom, it's not a disease. A symptom that perhaps some of the inner structures of the ear have been stressed or damaged. Otosclerosis is abnormal growth of bone that prevents structures in the ear from working properly. It's a hereditary disease, and it can be corrected with surgery. The success rate isn't the greatest, but oftentimes the bone can be, the excess bone can be removed, and then the other structures within the ear will work properly. Communication may obviously be difficult in a person who has a hearing impairment. So many people who have difficulty hearing will become lip readers. So it's important that if the patient does read lips, face the patient, make sure that you're making good eye contact with each other, and then speak to them. Don't use complicated language or large words. Talk slow at an even pace. There's no reason to over-exaggerate your pronunciation. Provide paper and pencil if the patient wants to write a note. If the patient uses sign language, you can ask for help from anyone that's present that may also know sign language. And consider using pictures to show basic medical procedures. Now, there are communication cards out there that you can purchase um, that have pictures of all types of illnesses and injuries, and they may be able just to point to something to give you an idea what they're feeling. If a hearing impaired person has hearing aids but they're not in, you might be able to assist them with their hearing aids. And hearing aids today are so tiny, almost unnoticeable. Many are Bluetooth to person's phone, so they can hear their phone ring. They can Bluetooth music to their ear and change the volume of the conversation from their phone. Just all kinds of wonderful new improvements with hearing aids. Visually impaired patients, they could be partially sighted, in which they need glasses, either nearsighted or farsighted. With low vision, that's a situation where they're unable to read even with glasses. And legally blind is when they have vision less than 2200 in at least one eye, or has very limited field of vision. And then, of course, totally blind or blind would be no vision at all. Causes of visual impairment include cataracts, glaucoma, macular degeneration, degeneration of the eyeball, the optic nerve, or the nerve pathways. Diseases. The number one cause of blindness in the United States is diabetes. Hypertension, injury to the eye itself, or brain injury affecting those cranial nerves that dilate and constrict pupil, or allow the eye to move up, down, left, right, or blink, or those sort of things. Infections of the eye, and then a vitamin A deficiency. Communicating with people who have visual impairments, orient the patient to the treatment that's being provided. Let them know. Imagine yourself with your eyes closed and somebody's going to start an IV, or somebody's going to get a blood pressure cuff. The patient can't see that you're not going to hurt them, or what you're going to do might be painful. So it's important to keep them informed of what's happening. Lead ambulatory patients instead of pushing them. Explain any movements in position so that you don't startle them, like if you're going to go from lying to sitting, or you're going to pick the board up and put them over on a cot, those sort of things. Retrieve visual aids and take them to the hospital, so glasses, those sort of things. And more and more often now we see guide dogs with those with visual impairments, and it's important not to touch the guide dog unless the person informs you it's okay to do that. Speech impairments. There are a wide variety of different reasons that people would have speech impairments. Stroke is one, a brain tumor, a head injury, hearing loss, delayed development, lack of stimulation, and emotional disturbances. Articulation disorder causes damage to the nerve pathways passing from the brain to the muscle in the larynx, the mouth, or the lips. So it's very difficult for a person to articulate the words or form the words with the muscles of their mouth, larynx, and lips because of nerve damage. Can be the result of a delayed development from hearing problems, and can also be the result of slow maturation of the nervous system. Voice production disorders. These are disorders that affect closure of the vocal cords. They could be either hormonal or psychiatric disturbances. Severe hearing loss will also cause these as well. Fluency disorder causes would be things like stuttering. Aphasia is loss of speech, or a slowness to understand speech. may lead to certain vocabulary and sentence structure problems as a result of not being able to speak. Apraxia is a neurologic disorder. It's a dysfunction of the cerebral hemispheres of the brain, and it leads to a inability to execute skilled voluntary movements despite their desire to do so, like speak. Speaking is a very skilled voluntary movement, and with apraxia and aphasia both, the patient may struggle saying the right word. Their words are very clear, but they may be the wrong word for what you're asking them. Verbal apraxia is a speech disorder, and that's the inability to say what the patient wants to say in a correct, consistent manner. It can be either acquired suddenly as a result of a stroke or developmental. Dysarthria is an articulation disorder, and these patients are unable to produce speech sounds. It can be the result of damage to nerve pathways passing from the brain to the muscles of the larynx, mouth, and lips, so their speech becomes very slurred, indistinct, slow, and nasal. Voice production disorders include things like hoarseness, harshness, inappropriate pitch, abnormal nasal resonance, and also can be caused by the inability of the closure of the vocal cords. Fluency disorders are repetition of single sounds or repetition of whole words, like Tourette's perhaps, speech blocking. So those are our sensory disorders. Now we're going to take a look at obesity. Obesity means a lot of different things to a lot of different people. Somebody may be morbidly obese. Well, what does that mean? There's a variety of different definitions. One is BMI greater than 30% is considered morbidly obese. One is 300 pounds or more is considered morbidly obese. Another might be, and one that I feel is more appropriate when you're talking about morbid obesity, is the inability to complete activities of daily living because of your weight. So if you're unable to bend over and tie your shoes because you're so heavy, then that would be considered morbidly obese. Certainly some complications associated with obesity include arthritis, coronary artery disease, early disability and death, higher risk of impaired mobility, high blood pressure, strokes, orthopedic complications caused by the excess weight on the joints, pulmonary dysfunction like pulmonary hypertension, sleep apnea, some forms of cancer like colorectal cancer, and type 2 diabetes. Not to mention the certain emotional complications associated with being obese. Discrimination at work and school, in the community, eating disorders, feeling depressed and rejected, isolating or stigmatized socially, low self-esteem, and poor body image. Treatments for obesity include weight loss programs, exercise, counseling, medications, and bariatric surgeries like having your stomach stapled or your jaw wired shut. Paraplegia and quadriplegia. This is nerve damage to the brain and spinal cord. Could be medical reasons like tumors or an atriovenous malformation, or it could be the result of trauma. And as you can see, depending on whether we're dealing with paraplegia or quadriplegia, here would be my guess would be a quadriplegic because his arms have to be supported. He's on a ventilator, so he's paralyzed from the neck down. And certainly with all that hardware, if he had a condition not related to his ventilator or his quadriplegia, like an appendicitis, it would be difficult to physically manage this patient. Some complications associated with paraplegia and quadriplegia, of course, are sensation loss, motor function loss, lower blood pressures, and that occurs with the dilation of the container. When you have a complete sever of the nerves, uh, all the vessels below the injury lose their motor tone and fully dilate. So your container is twice as big, it's half as full, the blood pressure drops initially, and even once you get the container full, remains quite low because it is fully dilated. Some special considerations. It's important to know the type of deficit that exists prior to the present incident with quadriplegia and paraplegia. Were they quadriplegic before? Did they have any sort of moving or sensation in any of the extremities? Be suspicious of hidden trauma. Uh, Bowel and bladder functions, abilities vary depending upon the paraplegia or quadriplegia. They might have an ostomy, which is a hole, ileostomy, or a colostomy. Ileostomy, of course, is coming off the ileum, and a colostomy is coming off the colon. They may be in traction devices and may have other adaptive devices like wheelchairs and those sort of things to get around, also to include ventilators. Talk about some mental challenges, looking at mental illnesses, and here's just a very partial list of probably the more common types of mental illnesses that we'll deal with in medicine. Attention deficit and hyperactivity disorder, autism and pervasive developmental disorders like Asperger's, bipolar disorder, borderline personality disorders, major depressive disorders, obsessive compulsive disorders, panic and severe anxiety disorders, schizoaffective disorder, and schizophrenia. Now, psychoses is where an individual loses contact with reality. And typically we see psychoses with those who are schizophrenic, particularly if they become paranoid, and bipolar patients may at some point have a psychotic event. You'll also see it with organic brain disease. Neuroses, the person remains in touch with reality, but they may be obsessed with obsessive compulsive behavior, all the way to depression, all the way to unrealistic fears and phobias about things in their lives. Some special considerations: get a good patient history to determine whether or not they had a history of mental illness. Find out what sort of medications they're on, and are they taking their medications. Are they using any sort of over-the-counter herbal products like St. John's wort or some of these other herbal remedies that are supposed to help with, make you feel better? And are they using any sort of alcohol or other drugs along with their psychotic meds? Developmental disabilities. Developmental disabilities are defined as an impaired adaptation in learning, social adjustment, or maturation. The brain does not develop properly, and the brain is unable to learn at the usual rate, so they're behind. They develop at a slower rate than normal. Some developmental disabilities include developmental delays in the ability to walk upright, fine hand-eye coordination, issues with listening, language, or speech, or even their social interaction. It may be very difficult to obtain an accurate and complete history in somebody with a developmental disability, and you may have to take more time to get the information that you want. Certainly look for nonverbal clues that would indicate what's going on with them. Down syndrome is a developmental disorder which may cause mental retardation. It is an extra chromosome. A Down syndrome patient, regardless of race, creed, or color, all have very similar characteristics. They have an enlarged anterior fontanelle, flat nasal bridge, a flat occiput, poor muscle tone, mottled skin, protruding abdomen, a very small mouth, and a very large protruding tongue, small birth weight, a rounded and small skull, short and broad hands with stubby fingers, short in stature, shortened rib cage, upward slant to the eyes with short, sparse eyelashes. The thing to keep in mind about Down syndrome children is that 50% have congenital heart defects, as well as other complications to include intestinal disorders, hearing defects, and other illnesses. The congenital heart defects may be, depending on the severity, may be treated at birth, or they may wait for the child with Down syndrome to get a little older before they have the heart defect fixed. Some special considerations: adjust your assessment and treatment strategies based on the patient's level of understanding, or even your level of understanding of the patient. Make sure you allow extra time to obtain a history. When you're dealing with airway management, certainly that large tongue and small mouth is going to make it very difficult to do any sort of airway maneuver. And their decreased muscle tone may compromise respiratory expansion, and their gastric motility is slowed, so they may have full stomachs. Some other mental challenges include those who are emotionally impaired, whether it's nervous exhaustion, an anxiety neurosis, a compulsive neurosis, those who suffer from hysteria. And it's important to differentiate between emotionally impaired and emotionally mentally impaired, because one is treatable and certainly one is not. With the emotionally impaired patient, they're going to have somatic complaints, things like body aches, joint aches, chest discomfort, rapid heart rates, short of breath, may have a feeling of choking, may pass out, those sort of symptoms. Where an emotionally mentally impaired patient is going to have impaired intellectual functioning. They're going to be unable to cope with normal life responsibilities. And some IQ classifications, not that we're certainly going to know their IQ, but a person with a IQ between 71 to 84 is borderline intellectual functioning. IQ of 55 to 70 is mild mental retardation. IQ somewhere between 35 and 55 is moderate mental retardation, and 20 to 40 is severe mental retardation, and less than 20 is profound mental retardation. But when dealing with people who are emotionally, mentally impaired, may require some extra time to do the patient assessment, may require extra time to do the treatment, as well as transport. Arthritis, not something we see commonly in children, but certainly is a challenge that we may have to deal with. If somebody has osteoarthritis or rheumatoid arthritis, both can be crippling. During the assessment, each joint the patient complains, assess each joint that the patient complains of having pain with, for warmth and deformity and range of motion, pain associated with motion, tenderness. Oftentimes, if they're not moving those joints because of the pain, the muscles will atrophy and shrink. Note the location and the type of movements that cause pain, whether it's flexion causes pain or extension causes pain, and whether the pain is active or passive. The pain occurs with movement or without. Cancer is another pathological challenge that we may deal with. Cancer is a group of diseases that allows unrestrained growth of cells in one or more body organs or tissues. Often patients with cancer, as you know, will be very ill. You need to get a thorough history and list of their medications to include their anti-cancer drugs and pain meds they may be taking. They may, if they have cancer and receive drugs on a regular basis, have things administered through a port. And as a paramedic, you certainly are allowed to access that port. They may be wearing transdermal skin patches that contain things like fentanyl or morphine. Um, and you wouldn't find those unless you did a thorough exam. Cerebral palsy is a non-progressive neuromuscular disability. It causes difficulty in controlling voluntary muscles due to fetal brain damage. There is a spastic cerebral palsy, which is muscles are stiff, permanently contracted, severe spastic quadriplegia. All extremities show motor impairment and muscle atrophy. Patients with spastic cerebral palsy may have seizures, may have mental retardation, and it's important that if their muscles are permanently contracted and they're in a twisted sort of position, that you don't forcefully manipulate or try to straighten them out. Athetoid cerebral palsy is damage to the cerebellum or basal ganglia. Characteristics include slow involuntary writhing muscle movements, speaking, eating, reaching, and grasping problems, swallowing difficulties, increased in falls. Swallowing difficulties certainly lead to an increased risk of aspiration and choking. Ataxic cerebral palsy. This is would be one with low muscle tone, poor movement coordination because of their loss of muscle strength. Depth perception is decreased. They have a decreased sense of balance, and so falls are common. And then mixed cerebral palsy could be spastic and athetoid cerebral palsy signs together. The spasticity is followed by an increase in involuntary movements. Cystic fibrosis is an inherited metabolic lung and digestive system disease. It's caused by a defective regressive gene on chromosome 7, inherited from each parent. It causes the bronchial lining glands to produce excessive mucus. So patients with cystic fibrosis are prone to chronic lung infections. They have the reduced ability for cilia to clear the mucus from the airway. They have a decrease in antimicrobial abilities of the airway. They then end up with an increase in bacterial adhesion to the airway. They end up having a irreversible destruction of the exocrine portion of the pancreas. So their inability to break down carbohydrates, fats, proteins, and nucleic acids don't occur, and they're not able then to absorb the nutrients from those, which causes malnutrition as well. Symptoms, they may have pale, greasy-looking, foul-smelling stools, chronic sinusitis or rhinorrhea, persistent cough with eventual purulent greenish sputum as you see in pneumonia, wheezing and shortness of breath, lung infections which develop into pneumonia or bronchiectasis or bronchitis, stunted growth secondary to malabsorption of the nutrients, abnormally salty sweat, failure to thrive, and very late onset of puberty. The problem with cystic fibrosis, in addition to everything that we've mentioned, is the pulmonary exacerbations lead to respiratory failure. If blood is present, they may cough it up, and they may, because they suffer from chronic hypoxia, one symptom that you might see would be clubbing of the fingertips. Cystic fibrosis also affects the GI tracts. They can have distal intestinal obstructions in the right lower quadrant, causing pain, sometimes a palpable mass. They don't feel like eating. They may vomit and be hyperglycemic. Your respiratory treatment goals are to increase mucus clearance from the respiratory system with percussive therapy, aerosolized hypertonic saline to loosen that mucus up, inhaled mucolytics like Mucomist, um, things that are going to break up the mucus, uh, reduce respiratory infections by taking oral and IV antibiotics. Multiple sclerosis is a progressive, incurable autoimmune disease of the central nervous system. Patches of the myelin in the brain and spinal cord have been destroyed. Signs and symptoms include weakness, fatigue, facial weakness, coordination difficulties, cerebellar dysfunction, loss of dexterity, hyperreflexia, ataxia, an increased risk of falls, some sensory loss, paresthesia, visual disturbances, nystagmus, vertigo, memory disorders, and attention difficulties. And of course, as the disease progresses, the signs and symptoms get worse. They may have difficulty solving problems, impaired judgment, urinary urgency to urinary hesitancy to urinary incontinence. Constipation may be common, impotence, extremities feel heavy and become weak, and they may have spasticity leading to painful muscle cramps. The neurological effects result of a formation of ectopic neurologic impulses, which leads to an inappropriate communication between the neurons. The negative is that the conduction blocks or delays the nerve impulses because of damage to the myelin in the brain, which causes all these signs and symptoms. Muscular dystrophy, it's a group of inherited muscle disorders, a slow progressive degeneration of muscle fibers, an increased weakness that spreads over the entire body. Duchenne is most common form of muscular dystrophy and more common in males than females. Myasthenia gravis is an autoimmune disorder. The muscles weaken and they tire easily. It's a result of attack of the lymphocytes on acetylcholine receptors of the voluntary skeletal muscle side of the neuroeffector junctions. It blocks antibodies of the immune system from being stimulated as well. So patients with myasthenia gravis, they may start their morning out, feeling pretty good, but towards the end of the day, their muscles weaken, they tire easily, they have to rest and recharge. With that depressed autoimmune system, they have to be very careful for potentially developing illness. Signs and symptoms include drooping eyelids, double vision, difficulty speaking, facial weakness, difficulty chewing or swallowing, difficulty moving their extremities, and weakened respiratory muscles, which of course can lead to all kinds of problems if they're unable to effectively cough and clear their secretion, as well as take deep breaths. The affected muscles worsen with use and they improve with rest. So, as I had mentioned, they may start their morning out feeling pretty good, but the more they use their muscles, the weaker they become, and they have to rest, recharge before they can carry on. Because the muscles aren't used as often and frequently, they begin to atrophy over time. A myasthenia gravis crisis occurs when the respiratory muscles cause the respiratory rate and tidal volume to slow to the point where they're almost entering respiratory arrest. The disease does progress to throat paralysis and then eventually death. Treatment is supportive. Transport, because treatment is supportive, we're just looking at the ABCs. See how well they're oxygenating and ventilating by both pulse oximetry and capnography, and a cardiac monitor as well. Poliomyelitis, which is polio, is an infectious disease caused by the poliovirus uh, uh, hominis. Is a result of direct fecal-oral contact, or indirectly it can be picked up in the saliva, the feces, the respiratory secretions, or in contaminated water. It enters through the mouth, multiplies in the intestine, and then spreads to the lymph nodes and the blood. It attacks motor neurons of the spinal cord and the brainstem, and signs and symptoms of polio include fever, malaise, headache, intestinal upset. Post-polio syndrome affects the patient decades after the initial infection, uh, with a degeneration of the nerves, so it's going to cause a lot of weakness in the same muscles that were originally infected. Treatment is advanced airway support, especially if the muscles were the muscles of the respiratory system, bladder catheterization if they are incontinent, and there is no definitive treatment for polio, post-polio syndrome. There is a polio vaccine, but once you have polio later in life, if you develop post-polio syndrome, there is no treatment. Spina bifida occulta is when there is a hole in the spinal column. You might see a small dimple or a tuft of hair in the midline lower lumbar region of the back. With spina bifida occulta, the meninges in the spinal cord are not exposed, but with spina bifida meningocele, the spinal cord remains in the spinal column, but the meninges bulge out, and you have a pouch um, outside of the spinal column filled with cerebral spinal fluid. And it's most evident in the lower lumbar spine. Spina bifida is the most severe when the exterior pouch originates in a hole of the lumbar spine. The spinal cord actually protrudes from the spine. It's also associated with hydrocephalus, cerebral palsy, and developmental delays. Hydrocephalus is cerebral spinal fluid accumulating in the ventricles of the brain. It may lead to mental retardation, seizures. They'll place a shunt inside the brain to drain off the excess fluid, and of course anytime you have a shunt, complications would include meningitis. If the shunt becomes plugged, rise in ICP, bulging of fontanelles. They may have changes in their level of consciousness, headaches, vomiting, lethargy, seizures, irritability. Arnold-Chiari malformation is when the brainstem and the cerebellum extend down through the foramen magnum into the cervical portion of the vertebrae. When they hyperextend their head, it puts pressure on the brainstem and the cerebellum and causes apnea. Spina bifida patients, particularly children, are prone to latex allergies, not as much as they used to be, but they were prone to latex allergies because of all the surgical procedures that they had, all the contact they had with medical equipment, like blood pressure cuffs, masks, stethoscopes, airways, goggles, gloves, gowns, suction tubing, all those things back in the day had a lot of latex in it. And so they became allergic to latex, and many still are prone to latex allergies. You'll have patients also who have previous head injuries, and when dealing with a patient who had a previous head injury, it certainly can affect their cognitive, physical, and psychological skills, and may be challenging to deal with that patient as well. Patients with previous head injuries may have physical deficits, may not be able to ambulate, may have issues with balance or coordination or fine motor skills, may have issues with muscle strength or endurance, may have issues speaking, processing information, issues with memory or perceptual skills. Cultural diversity is what we're going to talk about next, and cultural diversity are differences of any kind from um, what where you are. Um, so differences in race, differences in class, differences in religion, differences in gender, differences in sexual preference, differences in personal habits, differences in physical abilities are all considered part of cultural diversity. Cultural considerations focus on treating the individual, not the culture. The individual is the foreground. The individual is what's in front of you. The individual is a um, breathing, living human being with needs when 911 is called, and they need to be addressed. Their culture is in the background. And what we're seeing, certainly in very diverse communities, is that different generations within the same family have very different beliefs. And we also know that not all people will identify with their ethnic background, but do keep in mind that all patients share the same types of problems. All patients, regardless of culture, are placed in similar situations. If we are aware of their cultural needs, we should respect the integrity of their beliefs. In some cultures, people may not share your explanation of the cause of illness, but may accept conventional treatments. Um, when I was in Greece and I was helping teach over there, that was something that we saw frequently. And what I had questions about was um, patients had no real say or no real involvement in their treatment. They came to the physician with symptoms. The physician assessed them, told them what they were going to do, and did it. There was no, I want a second opinion, or no, well, I've been on some.com and they say this. There's just no discussion. Um, you don't have to accept the person's culture. They don't have to accept yours in order for treatment to be effective. Again, the culture's in the background, the patient is in the foreground. Um, don't let your cultural assumptions, don't let your prejudices, don't let your belief systems interfere with your patient care. We all have prejudices. When that pager goes off at 3 o'clock in the morning for somebody in a ditch, and you're rustled out of a dead sleep for yet another whatever, you may roll to the scene thinking, oh great, I got another drunk who's put it in the ditch and got me up out of bed and this, that, and the other thing, only to come to find out the person may have had a heart attack or a diabetic emergency. So it's important not to let your prejudices get in the way of patient care. Some special considerations with cultural diversity include all patients will be anxious during an emergent event. When they call 911, when you get there, it may not be an emergency, but to them it is. That's why they called 911. So we have to go in knowing that all patients will be slightly anxious during their emergency. Attempt to communicate in your given language first. If you can't, because they don't speak your language, or use signs, pictures, or gestures. Certainly can use family members that may speak both languages. Notify the receiving hospital of the cultural difference and perhaps the need for an interpreter. Perform procedures slowly if time permits. Private space is culturally defined, or how close you can get to an individual is defined by culture. Personal space is more what I'm referring to here, and that's what that should have said was, your own personal space, regardless of your culture, is different for everybody. Don't invade my personal space, and it's usually about 3 feet for most people. It's best to point to the area to be examined and get permission to touch them prior to the examination. Patients with terminal illnesses, advanced stages of disease with unfavorable prognosis, requires empathy and compassion. Gather what history you can. Ask about advanced directives. And you may be told the patient is on hospice. Which brings us to hospice care, and the whole purpose of hospice care is to allow death with dignity in the home under the patient's own terms. But it doesn't mean we shouldn't assess and treat pain. Patients with terminal illnesses are often in a lot of pain and may have transdermal patches, whether they be fentanyl patches or morphine patches. Assess vital signs and level of consciousness. Try to get some sort of medication history from the hospice nurse that may be present or the family before contacting medical direction on any other further pain management. Patients with communicable diseases are also a challenge. Exposure to infectious diseases is at risk for EMS providers, and that's why we preach universal precautions, wearing your proper personal protective equipment. Some special considerations is that with communicable diseases, the psychological aspects of care. A person with a communicable disease who knows they have a communicable disease may warn you or alert you right away, but certainly they're attuned to your verbal communication as well as your nonverbal communication about your fear of them or getting their disease. Remember that each patient is an individual with unique healthcare needs. Respect their personal dignity. Provide considerate, respectful care focused on their individual needs. Financial challenges. When a person, that's one of the big reasons people don't call 911, because of the cost of healthcare. People are apprehensive about seeking medical care. Explain to them that their ability to pay should never be a factor in obtaining emergency health care, and that federal laws mandate a medical screening be provided regardless of a person's ability to pay, and that payment programs are available, and that government services are available, and that there are free or near free healthcare services available at some local, state, and federal organizations. Tracheostomies provide protection against aspirated secretions. Obstruction of a tracheostomy requires immediate action. You may have to suction a tracheostomy. If the patient has no trauma and we're transporting them with a tracheostomy, they should be in upright sitting position. Central venous access devices. Here they'll talk about Hickman's, Groschamp's, Portacaths, all those sort of things. They provide extended access to veins without need for repeated venipunctures. You can have a PICC line, which is a peripherally inserted central catheter. The benefits of a PICC line certainly include it's less costly than going into a hospital and having your IV restarted every 3 days. They can be left in for up to a year. They use the antecubital vein. There's little risk of infection. They say they may become dislodged easy. If it's placed properly, the PICC catheter goes in the AC and ends up seated right above the right atrium. So you'd have to pull a lot of that out of there for it to become dislodged. Tunneled catheters like Hickman's or Broviac's, these are for long-term therapy. They're easy to use for self-administered infusions. They do require flushes, whether it be with heparin or saline. They have to be clamped when not used. They have to be kept dry. With any sort of indwelling catheter, there's always a risk of infection. They do protrude from the body, so they are susceptible for getting caught on things and maybe pulled at. Implanted ports like a Portacath or Infusiport or Mediport or a PowerPort. Again, these go under the skin, and there's nothing hanging out. They're used for long-term therapy. There is a reduced risk of infection because nothing's hanging out. There's just a slight bulge on the chest. It's safer than other ports, reduced cost to the family. It doesn't restrict physical activity, and it only has to be heparinized monthly and after each infusion. You got to pierce the skin to access the port, and you need a special needle. There's a little bit of pain associated with the needle insertion. You must prepare the skin just like starting an IV. The catheter may become dislodged from the port, and generally these patients are not allowed to engage in contact sports, and these patients often aren't able to do self-administration infusions with these type of ports either. Vagus nerve stimulators are used in patients over 12 years old. Provides a pattern of stimulation to the vagus nerve, used to stop seizure activity. The generator is implanted under the skin. If the heart rate is slow, suspect the generator is stimulating the vagus nerve, causing a release of acetylcholine and slowing the heart rate down. Apnea monitors warn when the patient becomes bradycardic. Children, when they or even adults, when they become severely hypoxic, develop bradycardia. Gastrostomy tube. This is in patients who cannot take food by mouth for an extended period of time. They may have other chronic diseases, and that's why they have to have a G-tube. They may have CNS disorders, digestive system disorders, or their developmental disability may hinder them from taking food by mouth, and so they have to be fed through a tube. Initially, they might be fed through an NG tube or an OG tube, but if it's going to be long term, then they'll put the gastrostomy tube right into the abdomen and come out the wall of the abdomen. Emergency information form. If a patient is a child, ask the parent or the caregiver, the school, if emergency information form is available. It's going to relay pertinent information that may affect treatment. Some additional considerations include focusing on the patient's abilities, avoid using the word normal, develop creative means for communication with these patients, treat them with the same respect that are afforded to all other patients. Get the family involved because the families are the experts in the special challenges. If you've got a technology-dependent patient, who better than to know how to treat that than the family? They're taking care of that patient every day. They're often very comfortable with the home ventilators, with the tracheostomy tubes, with the G tubes, understanding that these things become plugged and fall out and those sort of things. Frequent hospital visits may create an emotional roller coaster with families as well. They may be stretched financially thin, as well as have no spare time to themselves. Certainly it's important to acknowledge that frustration. If a child, the siblings may need attention from the standpoint of if that sick child requires all the parents' time and energy, the other siblings may not get the attention they need as well. Guidelines for disability awareness. Use disability instead of handicap. Refer to a person first and to the disability second. Use a child with a disability instead of a disabled child. Do not refer to the disability unless it's relevant. Never refer to someone as a wheelchair bound. A wheelchair makes a person more mobile. Avoid negative descriptions whenever possible. Use typical or people without disabilities when describing people without disabilities. And with that, If you have any questions, you know how to get a hold of me. Thanks, and I will talk to you soon.